Thank you. Well, as Shanti just said, I'm Margo. I'm from KU Leuven, or University of Leuven in Belgium. And there I'm working at a Research X Design research team. And that's a team that actually focuses on design, space, and technology in various relationships between these three. The research group is led by Professor Anne Heilige and Professor Andrew van der Moer, and Professor Heilige mainly focuses on the relationship between design and space, design processes and practice, spatial experience, and inclusive design, and I'm mainly working with her, and within this range of things, my research is based in healthcare environments. And then the other professor, Professor Andrew van der Moer, focuses on space and technology, and he looks at data visualization, interaction design, so a whole other branch of the relationship between these three. Anyway, as it's still quite early in the morning, I'll take you through a little story, a little tour through a hospital. This room that you see here, well, I should actually not call it a waiting room, but I should call it a waiting lounge, is the first place where you come in when you enter a day surgery center in a suburban Belgian hospital. And before you come here, you received a letter in which you're approached as a guest in the hospital. And that's also what this space wants to communicate to you. The hospital put a lot of effort into designing this as a lounge in a hotel. And, well, that's also what patients experience there. Some of the participants in the research told me, well, I have the feeling here that I'm in a hotel at the Mediterranean Sea. Well, that would be good if I would be at the Mediterranean Sea. But I'm here to receive treatment. I have to undergo a clinical procedure. This doesn't really sound quite right. Well, after a short or a long wait, someone will come and take you with him or her, and they bring you here. So it's a walking day surgery center, so the idea is that you don't get assigned a room, but that you get changed here, take off your clothes, you put all your clothes, your belongings in one of these lockers, you put on your hospital gown, and you can then wait on a plastic chair there at the end of the corridor. The association people make here is not that of a hotel at the Mediterranean Sea. I hear things like, it looked like a swimming pool, that's still recreational, but also it looks like the changing room at a factory. But we're still in the hospital. So the next place where you go is here. Well, here you already get this clinical sense. Every patient gets assigned one of the cubicles here at the right side of the picture, and there your blood pressure is taken, and you're prepared for the procedure which you will go through. Okay, we have changed situations. Then you're walking behind one of the nurses, and you enter here. This is the operation room, just like any other operation room in the hospital. But you're not wheeled in, you're walking in. So you have no choice whatsoever in how to deal with this space. You cannot close your eyes to retreat from it. You're bumping into something, you're walking, and you cannot adjust to the space on your own pace, because you have to be following someone who's holding your drip. Anyway, that's the next situation. And then, after your procedure is done, you can go back to the Mediterranean Sea. We're back in the recovery lounge. Here you get a coffee or a tea, and you can talk to your doctor, and then you're dismissed from the hospital. So, well, the hospital put a lot of effort into communicating their philosophy of care towards their patients, to tell them in their spoken and written communication that very explicitly that they're guests, that they want to receive them and take care of them. But implicitly, the built environment is not telling this story, or at least it's not very consequently throughout all the spaces. So for us in our research group, it's very important to communicate this kind of things to architects and designers in general, because just knowing these things from ethnographic research in architecture is not enough. We also have to get these things into the minds of architects. And what we often get asked is, are there good examples? Because here you saw that what was full of good intentions, but the reality didn't really go with it. So I like to give the example of the Maggie centers. The woman you see here is Maggie Keswick. And Maggie Keswick was the late wife of Charles Jenks. I don't know whether there were some architects in the room. Charles Jenks is a very well-known architecture theoretician. And well, Maggie herself, she was a landscape architect. So they were both very convinced of the important role space could play in people's experience. And when Maggie was told that cancer she had been battling before had returned, and that she had only 3 more months to live, the doctor sent her out of his room, and this was the kind of environment where she got into. Plain hospital corridor, not really the place where you want to get through with this kind of information. And the only spot where she could go to cry and to be by herself was this. And Maggie and Charles thought, well, this is not the kind of environment we should provide for people in this kind of situations. So they set up the Maggies Trust, and the philosophy of care of the Maggie Trust, or their aim, is actually about empowering people to live with, through, and beyond cancer by bringing together professional help, communities of support, and building design to create exceptional centers for cancer care. And that's what they did. They brought together very exceptional architects like Zaha Hadid, like Roger Sturck Harbour and Partners, Frank Gehry, like the big and famous, let's say, and they asked them to design these cancer care centers for everyone affected by cancer, not just for the patient, but also for family, relatives, friends, anyone. And the centers really had this aim of welcoming people. They're not clinical at all. They don't provide any clinical service. They just want to welcome people, support them, and make sure that they're well informed and that they're stronger throughout their treatment process. And the architecture plays an important role in that. Or that at least was the aim of Maggie and Charles. To do so, obviously, it's not that easy to communicate this very lived-through vision to architects. So they also put quite some effort in designing the design brief, or setting up the design brief. And this design brief is what I like to call an experiential design brief, in which they don't really address numbers or very practical things. Well, they have some in it, but mainly they try to give very information in a rather brief way about how it should feel, how the building should be experienced. So they, for example, tell you the kitchen should be relaxed and inviting enough for anybody to feel welcome, to help themselves to coffee or tea. So when you come in there, you should feel kind of at home. This interior spaces shouldn't be so open to the outside that people feel naked and unprotected. They should feel safe enough inside that they can look out and even go out if they want it. That's this relationship between in and out is a very important one. When you're inside, it should empower you to step out into the world and be, more sure about yourself as a person, and also in your patient relationship towards clinicians, but also coming into the center, they took into account this feeling of safety. Every one of the centers has this entrance, which is delayed entrance, so you can always think, no, maybe not today, I'm not ready to go. And you can always leave again without people seeing you and you feeling like to really go in. Then something else, they also wanted, something else in the design brief, they wanted to have the minimum possible administration office type of atmosphere. So they didn't want there to be a desk and you coming in and having to go to the desk and say, I am Margo and I would like to see someone. No, they wanted the building to be welcoming and you should just walk in like you would want walking to someone's house. So there are no doors with fundraiser on the outside. They want an ethos and a scale to be domestic. And therefore they need to think of all the aspects of hospital layouts which reinforce the institution, like corridor signs, secrets, confusion, and they don't want them in their buildings. So they're not there. Hardly any of the Maggie centers have a corridor. There are no signs on the door saying consultation, toilet. There is not even signalization for the emergency exits, and that was a big fight against regulation because for fire and safety, but they got through it because of the scale of the building. But those things were very, very important. It should be a normal house to get into. And it worked. Like, these are the interiors of two of the Maggies centers, the left one in London and the other one in Dundee. As you see on the left one in London, you can see through the stairs that you see the front door, and when you come there, you ring the bell. Since it's London, you cannot just walk in, and someone comes up to you, they say, "Hi, I'm whoever. Do you come in? How are you feeling? Do you want a cup of tea?" And they take you with them to the main kitchen table, give you a cup of tea, sit down with you, and the conversation unfolds. So, well, we were quite curious whether that's the whole philosophy, that's what they aim for, but is it also experienced like that by the people using the buildings? So we did an ethnographic study both in London and in Dundee. Well, it was a rather short-term one, so it was mainly based on focus group interviews with clinicians, but also with many people, relatives, patients and former patients. And indeed, when they told us about their experience of the building, they said, yeah, it's a bit like coming into a gigantic womb. Coming in, the whole thing sort of unfolds you like, yeah, the building is giving you a great big hug. So I think these architects did a pretty good job in living up to what Maggie and Charles Jenks wanted, and what they also put so much effort into communicating to them. There's no end to it. It must be a word for, well, the building is unconditional. So, how did this philosophy of care go together with the built environment? Well, quite well in the Maggies centers. And why is that? Probably because they took into account, or at least that's what came out from my previous research, but also from some of my colleagues, that they took into account that the built environment is experienced through all our senses. Not just the visual picture is all right. It's not just a big architect who made this really pretty building. It's also like the sense of every one of these rooms, how they go together. All these things are, well, consequent, let's say, are in line with one another. And the built environment is experienced in motion. You don't, if you just design a very pretty patient's room, but every other place where the patient is wheeled through or walks through communicates something else, then we're here to care for you. That will not be his or her experience. In motion means throughout the whole journey of a patient or a person making use of a building. So, well, I'm happy to receive any questions, and there's one thing I want you to take home, then it's make sure your philosophy of care goes together with your built environment, and that both communicate the same thing throughout the entire journey. Thanks.
Right.